My name is Dr. Steve Lowinger. I have a practice in North Miami, Florida. I've been practicing there for 15 years. Big fitter of multifocal lenses, going back to when the first soft disposable multifocals came about. Fitting lenses now for a long, long time, and big fan of the Air Optics multifocal. We do pretty much multifocal start to finish, and we use that lens pretty much using the fitting guide and the way the fitting guide tells us to do things. The lens has been around for about 2 years. In the time of fitting that lens, and I've probably gained 200, 300, 400 patients that way, of patients who have just word of mouth gotten that into multifocal, and it's a big deal here in my practice. When you have a patient who's just starting out with having issues at reading, you'll be tempted to do what I call monovision, which is you're going to back off the prescription a little bit just so they can capture a little bit of reading. It's an easy fix, but it leads you to a trap, which is as they go from 42 to 44 to 46 to 49, you end up in true monovision. The problem with that is you're creating that extra splay between the vision, and they start to feel that compromise in their vision, and they start to tell you about that compromise in their vision. The problem there is then when you decide to make the jump to multifocal, you've created an issue where they've got to relearn some habits. By doing that, you've created a spot, maybe not today, maybe not tomorrow, but there's going to be some point in your relationship with that patient where they're going to need to transition to something that's going to be more challenging for them, at least initially, than it would have been had you not done that from the start. To me, it just makes more sense to use a low ad on the multifocal, get them into the multifocal that way, and then transition the powers accordingly afterwards. The other problem with that is, and I've seen this happen on the opposite side, where a patient will be in monovision from another doctor. And the doctor may have just done a small transition, but the patient has not wanted to tell that doctor that this was something they were unhappy with. And then their friend, who's a patient of mine, tells them about how I'm wearing a multifocal contact lens and it's working very, very well for me, and there's my new patient. Because they come into the office figuring that their doctor doesn't have the skill set to fit them with multifocal, when it's not a difficult skill set to begin with. It's just because you didn't put all the options on the table, the patient didn't even know that you were able to do that. So all of a sudden you lose a patient, not because you can't fit them with that multifocal, just because you decided to save them the trouble of getting used to something when you should have been prescribing initially what was best for them. The most important thing I'll say to anybody fitting multifocal for the first time, or transitioning from a different modality that you felt is the proper way to do this to this modality, is be patient with it. It requires you to use a fitting guide, learn the system, and do it properly. When prescribed properly and explained properly to the patient, 80 to 85% success rate. Okay? There's going to be that 15% they're going to end up in another modality. That's fine. But what you'll find is as you get really, really comfortable with this, it becomes second nature to you, and it becomes a lens that you almost reach for first.